I remember my mom always telling me, don't ask, don't tell, in regards to illness. For my Chinese family, being sick is a taboo, so we never talked about it. When I became pregnant with my first child, I find out I have hepatitis B. I was very shocked. Only then did I learn from my mom that she also has chronic hepatitis B virus, and that I probably got it from her. I know the transmission wasn't her fault, and yet I wish she had told me sooner. I decided I wanted to do motherhood differently. I was blessed because my OBGYN knew what to screen for and took precautions to prevent transmission from mother to child. My 2 children got vaccines at birth and then completed the 3 shots afterward. When they were retested at age 1 and again at age 2, the test came back negative. But my doctor told me that because I have chronic hepatitis B, I have a 25% chance of getting liver cancer. Will I be able to see my children grow up to adulthood? Will I have to leave them too early? I chose to be very open with my children about the virus, and I started reaching out to Asian communities too. When my children attended Chinese language school, I set up a hepatitis education booth for parents. My children manned the booth with me and talked to their friends about vaccination. Later, when they left home for university, they continued doing hepatitis B outreach on their own. I did too. I remember my son coming home during a school break and saying, "Hepatitis B is a silent killer. Testing is so important, and vaccination can prevent the infection." I told him, "You got it. I am so proud of you." I used it to think my passion for preventing hepatitis B would live in me until I die. Now, I think it will live longer than that. Just be grateful.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
집에 왔는데 와이프가 저녁을 차리면서 진단 잘 받고 왔어? 근데 한마디로 나 간암이래. 전부 그 침묵이 흘렀죠. 그 마누라가 와이프가 여보 내 간 줄게. 많이 울었죠. 안녕하세요. 저는 민경윤입니다. 현재 65세이고 여태까지 그 한 직장에서 35년 동안 근무하고 은퇴한 지 한 7, 8년 되고 있습니다. 6남매 중에서 5남매가 수직 감염이 됐습니다. 그래서 제가 막내인데 두 형님들은 그때 당시만 해도 치료약이 없었기 때문에 간경변으로 해가지고 50대 초반에 돌아가셨고 어머니는 59에 돌아가셨습니다. 그래서 결국에 또 59세에 또 간암 발병을 했죠. 저도. 그래서 이런 그 비형 간암의 그 집안 내력이라는 게 상당히 좀 뭐라 그럴까 어떻게 보면 무서운 거죠. 그 환우들 모임이 있더라고요. 그래서 그 모임에 들어가서 이렇게 좀 제가 알고 있는 지식을 가지고 답글을 써주다가 직접 운영하는 카페도 운영해가지고 그 환우들이 몇만 명씩 지금 들어와서 제가 쓴 글을 보고 공부하고 제 치료 경험을 토대로 해가지고 답글을 써주고 또 병원까지 안내하고.
간염 보유자들은 자기를 드러내지 않고 굉장히 감추려는 그 본능적인 방어가 심합니다. 이 사람은 굉장히 모범적인 간암 환자로 많은 사람들한테 등불이 되어주려고 노력을 하고 있으니까 그 책임감만으로도 이 사람은 앞으로 굉장히 건강을 잘 유지하고 천수를 누리겠다라는 저는 아주 굳은 믿음을 갖고 있습니다.
또 치료도 잘 됐다고 하는 그런 걸 들을 때마다 많이 좀 어떤 성취감도 느끼고 보람도 느끼고 있습니다. 솔직히 그 만성 비형 간염 질환은 누군가에게 큰 부담을 주지만 또 정기검진을 안 받고 조치를 취하지 않은 대가는 훨씬 크다고 생각합니다. 젊은 세대와 우리 같은 기성세대 친구들과 지속적인 그 협력 속에서 온라인에서 커뮤니티를 구축하여 우리 그 비형 간염 보유자들에게 지속적인 도움을 주고 싶습니다. 정말로 두려움 때문에 여러분의 건강을 돌보기 위한 노력이 지연되지 않도록 하시길 바랍니다. 자신의 상태를 아는 것이 자신의 생명을 구하는 지름길입니다.
Okay, here we are. Welcome to the afternoon plenary. Welcome everyone in the room and everyone online. Again, my name is Kerry James, and I'm the Chief Executive here at the World Hepatitis Alliance. And thank you so much for joining this session, Hepatitis and the Sustainable Development Goals, working together with the wider SDG movement to accelerate hepatitis elimination. And we've got a great panel, both in person and online. And I'll just remind you that you can put your questions in the Q&A box on the platform, and then we'll come back to those at the end. And the people in the room, you can just raise your hand or raise your name card there. So great. So SDGs are, according to the official website, a blueprint to achieve a better and more sustainable future for people, for all people and the world by 2030. And I think we hear a lot about SDGs, and especially if you're working on the global level, but even on a national level, the importance to achieve them and to address them. And I think especially maybe in the hepatitis community, we don't talk about them enough. So I think this is an opportunity for us to explore the SDGs, to explore the idea of kind of wider determinants of health and how it can really help accelerate our hepatitis elimination programs. So first, maybe I'll just do a quick round of introductions. Online, we have Doug Webb from the United Nations Development Program. Hi, Doug. Thanks for joining us. We also have Dr. Jose Zuniga from the International Association of Providers of HIV Care, IAPAC, and the Fast Track Cities Institute. Hi, Jose. And also online, we've got Dr. Ricardo Baptista Leite from Unite, the Parliamentarians Network Against Communicable Diseases. And I think maybe Ricardo's just going to join us in a moment if he's not here already. So we'll look forward to that. And on the stage with me, on the stage with me now, we have Dr. Julia Tanioki from the World Medical Association, Dr. Justin Kunin, he's the co-chair of the UHC 2030 Partnership, and Professor Mohammed Ali from the National Liver Foundation of Bangladesh. So thank you all for coming. I think I'm the worst qualified person on the stage at the moment, so I'll try to live up, work up to that. So I think we're going to begin with just a round of all the speakers, and for some initial remarks, and then we'll be taking questions from all of you. So maybe, Doug, we could start with you, and maybe you could just give us a little bit of an overview of the work of the UNDP and about the SDGs agenda generally, and the importance of not just addressing one of the SDGs, but really kind of addressing them together, and what that means for communicable diseases like hepatitis. So, Doug, over to you.
Hi, Carrie. Hi, everybody. I hope you can hear me. I'm having connection problems. I'm in New York, which is sometimes a developing context I'm discovering. Just some overview, some thoughts on the SDGs, why they're important, why they matter. They've been called a forest of Christmas trees. Sometimes we don't understand why they're useful. Why should we look at hepatitis through an SDG lens? 17 goals, 169 targets. Target 3.3 is itself extremely congested. End the epidemics. I mean, this is a very high level ambition. So we need to look at the HIV, STI, and hepatitis strategy, which the World Health Assembly has just endorsed a couple of weeks ago, perhaps for any detail, but the accountabilities within that lie within the ministries of health, not within the whole of government. So we still need to look at the Agenda 2030, perhaps, when we're thinking about whole of government and whole of society accountabilities. But Agenda 2030 and the SDGs don't care about your favorite goals and your favorite targets. Let's remember this is concept of indivisibility, and they won't prioritize your goals and your targets without any particular justification. The price tag is $4.5 trillion a year. So you've got to make your case if in a fiscal space which is obviously contracting. The SDGs are only financed to the tune of 4 or 5%, depending on who you believe. Things are getting worse with COVID, of course, and with Ukraine, which is now being characterized as a fuel financial and now humanitarian crisis and a food crisis as well. And with COVID now, half of countries surveyed have reported that hepatitis diagnostic and treatment services have been disrupted. So things are looking difficult under any circumstances. But the SDGs is where the multilateral money is still being organized, huge financial flows. And as far as an organizing frame, it is still the North Star for the multilateral community for policy guidance and as far as vision is concerned. And with the high-level political forum coming up, and I'm reviewing the declaration coming out, it's still the only game in town as far as the way the world is thinking about development. So there is no alternative as far as development thinking. So for the hepatitis community, what do you need to be perhaps thinking about in terms of a few points to consider as you link hepatitis to the SDGs? Remember, there's three domains of interest: the environmental, social, and economic, which were previously seen to be exclusive or mutually exclusive, and now they're seen to be mutually supportive. So there's this attempt to look for accelerators or the sweet spot in these three domains. So how do you find interventions or policies or pathways which tie these three domains together? And that is where the attention and the money very often is targeted. So these idea of accelerators which tie different objective sets together. The overarching thought and policy environment objective is around this concept of whole of government, whole of society, which implies a lot of attention around coherence analysis, conflict of interest analysis, power and arbitration mechanisms. So there's a lot more thinking now around how do we mainstream a condition, a disease, across different objective sets, and where conflicts are potentially going to come forward. HIV has led the way, perhaps historically, but that was very much driven by external financing. So it may not be. The lessons are perhaps limited in there. Particularly for hepatitis, perhaps when the public and private sectors, the incentives are misaligned. When the market forces, are suppressing perhaps treatment access, what is the arbitration mechanism that's going to be most viable? And I think we've got a lot of challenges ahead of us, not just in hepatitis, but in other areas as well, around market shaping and the role of the state, where market failures are denying the right to health and the rights to treatment. And there's a lot of attention now being put on business and human rights within the SDG agenda. And the right to health is actually not prominent enough within this conversation. So the SDG does allow these conversations to take place, and commercial determinants is again another area of interest across the SDGs. Another major area is leaving no one behind in inequity reduction. This is a very important framing. But how do you value inequity reduction, perhaps when the unit costs of reaching the furthest behind are potentially higher in economic terms and in political capital terms? Key populations very affected by hepatitis are high political costs in terms of political capital to reach. We've seen the negotiations in the World Health Assembly being scuppered very often in terms of language and finding a universal consensus in terms of reaching vulnerable, marginalized populations. But the SDG agenda does stress universality, and this is an important political tool that can be used. Another point, SDGs do favor integrationist agendas. So it's important then that the value of linking the disease to systems approaches, the human resources, the value of systems development in reaching the disease-specific targets or objectives is actually amplified. And there you will find allies working in other disease conditions. Universal health coverage very often will be aligned with an SDG agenda and finding allies within other disease constituencies. Investment approaches are vitally important. I think linking hepatitis to how cost burdens are distributed, who's being affected most, return on investment analyses have proven very useful. Again, HIV has pioneered this. But investment cases or investment approaches must not be pitched in opposition to each other across diseases. They must be synergized and put together to contribute to universal health coverage. Legal environments, to link with Goal 16 perhaps, and look at again where discrimination is structured by institutional practice, legislation and fiscal space very often are where legal environments can and can push access to treatment particularly. Finally, there's perhaps some framings that should be considered when talking about hepatitis within the SDG agenda. There's obviously the public health frame, illness, death, disease burden, its distribution, health-related costs. There's generalized misery that's generated at a personal and societal scale. Fundamentally part of universal health coverage. This is the argument you're probably most familiar with. The second is developmental. The actors, the processes, integration, synergy across the SDGs, economic impacts, socioeconomic costs, fiscal space, inequity reduction. And again, that is the language very often the ministries of finance. Thirdly, human rights, the right to health, rights violations through denial of treatment and prevention services, the state as the duty bearer, patients as rights holders with entitlements. Finally, one that's emerging, a frame that's very important now is health security, of course, crisis, risk reduction and management, One Health approaches. And with COVID, vaccine equity. And there's new initiatives, lots of money, G20 money going in to vaccine equity, vaccination systems, which hepatitis B particularly could benefit from. Where is hepatitis within that conversation around health security and the pandemic accord that's being discussed under the World Health Assembly? So it's very often about who you're talking to, the language that you deploy, the money flows are very often in totally different places, but it's about that linking in with your multivarious objectives and how they fit within development, very often fiscal discussions and developmental pathways. But I would see yourselves as tying into other SDG dialogues at the moment. We've done this with other communicable diseases, non-communicable diseases to some effect. And I think it's an exercise well worth undertaking. Thanks very much.
Excellent. Thanks so much, Doug. And I think a lot of what we were saying about equity and leaving no one behind really resonates with the Alliance and really with this whole kind of conference. I mean, it's definitely something, I'm going to turn to you now, Professor Ali, the vulnerable populations you work with, vulnerable populations with hepatitis that you work with in Bangladesh. It'd be great if you could tell us a bit about that and the work that you do in Bangladesh.
Thank you, Kerry. Actually, we are working under the banner of National Liver Foundation of Bangladesh, a non-profit philanthropic organization and dedicated to prevention, treatment, education, and research on liver disease in Bangladesh, particularly viral hepatitis. And we have got this main agenda. First one is the awareness building. Second one is the advocacy. Third one is testing, vaccination, and then treatment and working against stigma and discrimination. These are the basic things, basic fundamentals on which the foundation is working since 1999. And we made awareness programs based on the themes of World Hepatitis Alliance and in the World Hepatitis Day. And we have got the innovative days, particularly awareness programs, which we conduct throughout the year, such as regional hepatitis days for awareness building in the district and divisional headquarters for the awareness building of the mass population, particularly grassroots activation. And we made other programs. Most important thing, we made patients conferences, hepatitis B and C patients and their families. We call them for conference with a direct interaction with the treating hepatologist. And this is a very, we get the highly incentive and is a very positive impact for awareness building. And we use other avenues, particularly cricket players and cricket supporters for propagating the message of viral hepatitis. We have created a network on the NOHEP network throughout the, particularly using the youth communities to pass the message of awareness message. And we have engaged medical students society of Bangladesh so that they can very easily propagate the message of awareness among the medical students as well as the doctors communities, and they are very working. We have engaged gynecologists and obstetricians for awareness making, and particularly convincing them, arguing them, pleading them for making a test for hepatitis, a rapid test for every pregnant woman for hepatitis B, so that unknowingly this hepatitis B should not be transmitted from the pregnant mother to the newborn, because they are the key physician treating gynecologist, and under their care the hepatitis B is passing from mother to child. And these are the awareness buildings. We made advocacy particularly with the government for coming forward with the national viral hepatitis control strategy. Particularly we made advocacy for birth dose. We made advocacy for reduction of the stigma and discrimination. So every time we engage them. We also made advocacy to other organizations, particularly liver organization, hepatology, or other organizations, philanthropic organizations, women organizations, children organizations, to pass the message so that it can be disseminated throughout the nation. So we are working in different aspects, and then we make testing, particularly vulnerable communities, children, and especially orphan children of the government children homes throughout the nation. Most of them areas we have covered, testing them and vaccinating these children. We made a school program for awareness. We made university, as there's University Hepatitis Days, one-day program in a university for awareness building of the university students. So, and then for treatment, we provide treatment with all maximum affordable cost, particularly linkage with the pharmaceutical societies, so that they can, people affected by the hepatitis B and C get the treatment. But still now, I will tell this, the cost of DAs for hepatitis C in Bangladesh is high. Particularly in, I will tell you, in the whole of the Southeast Asia region. And we are making advocacy to the government for coming down and making the policy so that the easily available of the drugs. Another thing we made also vulnerable communities, particularly drug addicts, thalassemia patients, hemophilics. We made advocacy for them and awareness and other things. So most important, recently we made a campaign testing and campaign, Rohingya refugees, displaced population, about more than 10 million Rohingya refugees are there. And we tested first the pregnant women, 300 pregnant women, and there was 8% pregnant women was positive for hepatitis C. Later on, we made a bigger survey and found that about 18% of the population of hepatitis C, of Rohingya refugees having hepatitis C, which is about 18 times higher than our host country, Bangladesh. We have published this in the Journal of Clinical Liver Disease of the American Study of Liver Disease. So we are working with the government, with the public, and with the peoples. And actually, this organization has created a positive image among the peoples that whatever you have the problem of having hepatitis B and C, you can approach the Liver Foundation, and we are very much cordial to them, and we always like to stand by them, by their side, by their families, by their children. So we are continuing. I think with this we can fulfill the goal of SDGs and also contribute greatly to the fulfill the strategies of elimination 2030. Thank you.
Brilliant. Thanks so much. It's just such incredible work that you guys are doing in Bangladesh. And if anyone is interested in finding out more, you can look on the World Hepatitis Day website, where there's lots of examples of the great work being done by Professor Ali and his whole team in Bangladesh. One phrase that's come up a lot today is universal health coverage. And I think it's a phrase that is in the world a lot. And I think maybe it's something that not everyone fully understands. So Justin is the perfect person to kind of fill us in. Justin is co-chair of UHC 2030. Can you tell us a little bit more about universal health coverage and how it can be used to help reach hepatitis elimination?
Thanks, Kerry. It's great to be here in person. So the 2-minute primer on UHC, obviously people will have different backgrounds, but probably all of you have at least heard the term. UHC is essentially SDG 3.8, and really it means that all people should have access to the health services they need, and it shouldn't put them under financial distress to do so. So there are two components. There's the access to services, and those services need to be of good enough quality to be useful. And secondly, there's the financial protection component. So and this happens a lot, we can't provide people services, but then push them into poverty to do so. The way that we often conceptualize UHC is it's sort of a cube. I might have to use my fingers. I don't have a diagram, but so you think of sort of 3 orthogonal axes, and the cube is, so who gets served with health services, what gets covered, and then how, in other words, how is it paid for? So I might go in backwards order, but often when people think of UHC, they're often thinking about only that last access, the who pays for it. And in other words, UHC gets sort of flattened into only talking about national health insurance schemes or something like that. And then people with specific health issues say, well, that's actually not what I'm talking about. And they lose interest. Or even worse, people working on specific issues who've spent many decades dealing with key populations and devise particular programs become a little bit afraid of UHC, because what happens to my specific programs if we're talking about these generic whole of society approaches which don't work? So that is obviously important, but it's only one dimension of what we're talking about. We're also talking about, well, what gets covered, and naturally people in the hepatitis community would hope that hepatitis is covered under UHC schemes. And what I would say there is that you can't you can't have UHC without hepatitis. That's clear that hepatitis is really a critical part of the puzzle. But also you can't end hepatitis without UHC. And why is that? Because UHC at its fundamental core is about strengthening the fundamental capacities of health systems, particularly with a focus on primary health care. It means having sufficient, well-trained, well-paid health workers. It means community engagement. It means supply chains. It means data and analytics. And all of these fundamental health system investments, which are critical to ending all of the major health issues that we're talking about, whether they are infectious diseases or non-communicable diseases or any other. At the end of the day, when a person goes for treatment, it doesn't matter what they're going for a treatment for. They go to one place, right? They go to a health center or a hospital and it's critical that those places are aligned in ways that provide services that are appropriate. And so that's why really all health conditions should have an interest in UHC. And then the third dimension of the cube that I mentioned is who gets covered. And here there's really critical questions around equity and key populations and making sure that the most vulnerable people are included. And there I can see a very obvious alignment between the hepatitis community and also the HIV community where I'm from, and UHC. So I would say to people working on hepatitis that you need to get involved in UHC because you need to fight for the UHC that you want, not some reductionistic approach that only talks about national health insurance schemes, but something which covers human rights, discrimination, vulnerabilities in their fully fledged glory as they should.
Excellent. Thank you so much. Thank you. So now we'll go over to Julia from the World Medical Association to hear kind of more the physician's point of view. And I think what we're talking about a lot is what's also called kind of health system strengthening, right? And kind of talking about kind of other determinants of health. So it'd be great to hear from your point of view the WMA's approach to that, and and how it maybe relates to hepatitis elimination. Thanks.
Thank you very much. Just a quick word before, there might be some people who don't know who WMA is. We are the international organization of all physicians worldwide. So we represent 9 million physicians over the world and have 150 national medical associations. So as a physician, the reasons why a patient might have hepatitis can be very different. And so our answers to this must be very different as well. WMA is quite glad to see over the last years that we are going away from a siloed, pure disease approach and to a more holistic approach with focusing on healthcare system strengthening. The last COVID pandemic, it's still going on, showed us that there are still many health systems which are still fragile. And one sign for this is WHO did a rapid assessment, and 122 countries reported a disruption of the non-communicable disease services. So just this one. It shows us we need really robust health systems to cover with all these challenges we are facing. And healthcare system strengthening, the aim is to exactly deliver this universal health coverage Justin just talked about, because everyone should have access to high quality care, regardless where they are, in which rural, urban place, in which country they are. And for us, the tool to implement universal health coverage is primary health care. A strong primary healthcare system which focuses on prevention, diagnosis, treatment, secondary care, and rehabilitation. And to deliver the healthcare system strengthening, the crucial element there is a health workforce. All health professionals and related workers who work for the healthcare system. And here, WHO estimated by 2030, we will have a lack of 18 million health professionals globally. The COVID crisis rather increased this dramatic lack of health professionals because of the poor working conditions, many health professionals left the health system. So we need, on one hand, more health professionals. They need good working conditions. They need to be well trained and equipped. And by this, we have retention strategies to keep them in the system and to attract them as well. For us as physicians in hepatitis, the prevention aspect is very important as well. And it's important that the government see prevention is not only a cost, it's rather investment. To invest the money now is much cheaper than to treat later on. And prevention can be very, very different. So prevention is the mother-to-child transmission of hepatitis needs a different prevention than someone who might be an alcoholic and becomes liver cirrhosis. And here the social determinants of health are important for us. So these are the health inequalities which cause the result of differences in the environment in which a person is born, grow, live, work, age, and dies. And these have an influence on our life, on our health. And so you could say, in other words, these are the causes of the causes why a person gets ill. So and this leads then as well to a person-centered healthcare approach, where you really put the person with its environment, the social environment, the family environment, into a perspective, and put this in the center and see, what can I do for this person to help him? This person-centered approach is very linked to continuity of care, where we link as well the health system with the social system, and have there really this continuity, not if someone leaves the hospital, we lose them out of the system. And here collaborative practice, so the different health professionals working together, which is not always the case in all health system, where a good cooperation, communication and respect to each other and the way to learn how to work with each other is very important. So that is how we see it in a very holistic way.
Excellent. Thank you so much. Thank you. Thank you so much. I think that the references to environment brings us very nicely to Jose from IAPAC and the Fast Track Cities Initiative. We've been very lucky to have a very great partnership with IAPAC for the last few years, bringing hepatitis conversation and action into the Fast Track Cities program. So Jose, it'd be great to hear about maybe just a little bit about Fast Track Cities for people that may not be familiar, and then talking about the work that you do around sustainable cities and that SDG, and just how you see hepatitis fitted into the Fast Track Cities program. Thanks.
Thank you very much for the invitation to join you. I only wish I could be with you in Geneva, but I'm stuck in this computer screen from which I cannot seem to escape. So I've been invited to speak about the Fast Track Cities Initiative, which is really a global network of more than 400 cities and municipalities. It was launched on World AIDS Day 2014. While it was initially focused on HIV with some crossover into the TB space in relation to co-infection, in 2019, the mandate was expanded to ending TB irrespective of co-infection, as well as embracing the WHO's goals of eliminating HPV and HCV by 2030. Our embrace of the viral hepatitis goals was a no-brainer for two reasons. First, with the significant advances in HIV treatment, we have the tools to guarantee people living with HIV near normal lifespans. So why then would we wish for them to succumb to comorbid and syndemic diseases? But second, why not leverage the HIV response to facilitate greater progress in the responses to HPV and HCV, for example? It is true, I think, that a high tide can lift all boats, and that's very well aligned with the health-related SDGs. So we've made some significant strides since 2019. Our partnership with the World Hepatitis Alliance, which Carrie just referenced, has yielded some unique opportunities to raise the volume around the need, for example, for clinicians to follow HCV screening guidelines, notably as we look at at-risk populations being screened at suboptimal levels, which jeopardizes our efforts to achieve microelimination in MSM communities, for example. We are also busy collecting best practices across the network on urban HCV elimination efforts. For example, our colleagues in Lisbon are using community-based pharmacies to offer point-of-care tests for HPV, HCV, HIV, and that way expanding opportunities to diagnose these three diseases outside of clinical settings, which some who've accessed these testing services have indicated are far less stigmatizing than clinical settings, the pharmacies are. In Madrid, our colleagues have been implementing an HIV/HCV screening program with embedded linkage to a care nurse. And in that way, they are actioning differentiated service delivery. Notably, only 3% of those diagnosed with HCV were lost to follow-up. And we sort of suspected that outcome. And some of you may recall in the HIV sphere that there were arguments against nurse clinical leadership in the HIV response, which of course was disproved. The notion that they could not exercise clinical leadership was disproved in large measure, where we started seeing even better treatment outcomes when people living with HIV had their HIV managed in a notable way by nurses and nurse practitioners. And in Amsterdam, our colleagues are offering testing and linkage to treatment to HCV care among clients who are attending homeless services as a means of conducting outreach to what has been traditionally a very hard to reach at-risk populations. If I look just at one segment of the data from the Amsterdam program, it indicates that 71% of homeless PWIDs linked to care and 57% were initiating treatment. That's a significant increase from baseline. And these are only but a few examples of the urban public health leadership that's on display around the world, from Bangkok to Kigali, New York City to Tel Aviv, which we'll be highlighting at our Fast Track Cities 2022 conference in Sevilla later this year. My concern is that the new global health sector strategy calls for 90% of people living with HCV to be diagnosed, and of those 80% to be on treatment. I love the metric because in large measure, the progress we made across the Fast Track Cities initiative in relation to HIV has been linked to the availability of data to inform decision-making around resource allocation and programming. Here, my concern is that the baseline, according to the data we have from 2020, is that only 30% of people living with HCV are diagnosed, and of those 30% are on treatment. That's an infinitesimally small number and significant gaps that I believe require business unusual. I know that Ricardo and my colleagues at Unite are aligned with the idea that cities and municipalities must be better integrated into the global HCV and indeed larger infectious disease response. And as Doug said earlier, we need a whole of government, including city and municipal governments, and whole of society focus. Cities and municipalities can be innovative, responsive, and timely in their efforts to attain HBV and HCV elimination. If we look at the HIV metrics I referred to previously, pre-COVID-19, Fast Track Cities made great strides, in some instances double-digit percentage point increases in people knowing their HIV status, placed on treatment and achieving viral suppression, which translates into two things. Number one, a near normal lifespan, but also undetectable equals untransmittable, meaning that people who have an undetectable viral load cannot transmit HIV sexually. That's an important game-changing paradigm shift that we experienced, which leads us to believe that we can achieve SDG 3.3 in relation to HIV, but only if we have the resources available and the, again, whole of government and whole of society push to do so. I think these achievements are critical to advancing national HIV responses, but also HBV and HCV responses, particularly in countries with a critical mass of Fast Track Cities, including the UK, South Africa, Brazil, et cetera. And thankfully, due to significant realignments in city and municipal HIV plans, most Fast Track Cities experienced only minor disruptions in HIV service delivery due to COVID-19. We have started mapping some of the experiences in relation to viral hepatitis and have seen some inkling of similar examples across the Fast Track Cities, indicating smaller proportion of cities where HCV, particularly HCV services, were disrupted, due largely to innovations that were implemented both with respect to policy, but also programming. So I want to end my opening comments just by saying that my key message to those of you who are participating in today's session is for us to leverage the experience and momentum in data-driven, equity-based urban HIV responses to achieve similar strides in the HBV and HCV responses, particularly because urbanization trends indicate that by 2030, urban areas are projected to house 60% of people globally. That's huge, and it requires a focus on urban settings. But as important, I think from both a public health and human rights perspective, given the fact we have a cure for HCV specifically, it will be a public health and human rights failure of a colossal magnitude if we do not begin to close the gaps across the HPV and HCV continua much sooner than 2030. Thanks very much.
Great, thank you, Jose. And I think the U equals U phenomenon in HIV, I mean, I think there's definitely things that could be, we could learn for hepatitis B and the access to hepatitis B treatment if we had the research that could back up the claim of non-transmissibility on treatment. So I think that's a really important point. Now we're going to go to Ricardo, longtime great friend of the Alliance and of hepatitis elimination, and he's from the Unite, the Global Parliamentarians Network. So Ricardo, it would be great to hear about just a little bit about Unite if people aren't familiar with it. And I mean, you guys talk about SDGs and you also talk about hepatitis and communicable diseases. So how do you see those two things being related and how they can move forward together? Thanks. I'm not sure if we lost Ricardo. We'll just give him a few seconds. Maybe he just accidentally pressed leave instead of unmute, which I do often, I have to say, in Zoom meetings, far too often. Okay, well, maybe there are a few things in the chat, so maybe we could just have a quick peruse through the chat, and then we can come back to Ricardo when he's back online. I mean, one person in the chat does quite rightly point out that one of the few SDG targets that was achieved in the last KPIs, in the last deadline, was the target around prevalence in under 5s of hepatitis B. So, I mean, we have already achieved one of the great ones, but that has been kind of uneven around the world, and that's something that we really need to look at. Ricardo, great to have you back, please.
I'm so sorry. I was disconnected exactly when I was going to talk. My apologies to everyone, and good afternoon, and hello, Kerry. It's great to see you and to see a World Hepatitis Summit back on the road. It's great to see Jose, Justin, and so many good friends, both in our panel and in the room. I just wish I was with you. I was in Geneva at the World Health Assembly, but unfortunately, I have to be in the Parliament once in a while, and we have a debate this afternoon here. But it's great to see the dynamic around hepatitis still going forward, and kudos to you, Kerry, really for making this effort go on in such difficult, challenging times, and to keep it clear to everyone, despite that in the political world, I fear that many times it has fallen off the agenda, as with so many other phenomena we have lived through, like HIV, where we create the false sense that these issues are done with, we do not need to do anything more. That false sense of security is absolutely false, as I said. And so there is a need for us to continue to raise awareness and to push the agenda forward. As you mentioned, Kerry, and following up on your request, Unite is a global network of parliamentarians committed to global health issues. I can announce actually for the first time publicly that we just had our global board meeting in which we changed the scope of our organization from infectious diseases to global health. So now we are the Unite network, parliamentarians network for global health. And as a network, we are currently present in more than 80 countries. We are more than 250 members of parliaments, congresses, and senates from around the world. And all of these representatives of different countries and regions have come together with a joint purpose of doing our jobs as parliamentarians in the global health space, taking science from research and recommendations from trusted organizations like WHO and others to becoming more than recommendations, taking them from recommendation into concrete policy, and then making sure that the budgets are allocated where they are needed, getting the funding where it is needed. And our role as members of parliaments, congresses, and senate is also in line with the need to keep governments accountable. And that is a very important part of our work. And of course, being at the interface between people and governmental power, we have a very important role when it comes to raising awareness and getting these issues in debate within our constituencies. And we work at all levels, including at local government. So picking up on what Jose was saying, the extremely important role of urban settings when it comes to ending communicable diseases in that context. So our role today, of course, as Unite, is very much focused within communicable diseases, where we started off. And there is sadly a great backdrop, so to say, when it comes to the Sustainable Development Goals, particularly due to the COVID-19 pandemic, but also moving forward, even with the war in Ukraine. In the political space, we are seeing a deviation not only of the media agenda, but also of funding from health to defense, which is understandable, for example, in the European context, but it is of great importance that we do not lose focus of our goals moving forward. And when we look at the SDGs at large, and in September last year, before the start of the Ukraine war, we already had identified a 100 trillion US dollar gap to achieve the 2030 targets. And so with inflation as it is today, the lack of predictability moving forward, the tremendous challenges ahead of us, the uncertainty of the times we are living, when we look at hepatitis, be it hepatitis B, hepatitis C, where we have concrete tools for prevention, for curing disease, it is of overwhelming. It is an overwhelming challenge for all of us to make sure that governments at all levels keep focused, and that is what we are aiming to do as representatives in parliaments. Unite, as part of this effort, has joined forces with the parliamentary network of the World Bank and IMF, and we have created the International Forum on Global Health, which is an umbrella organization, which is a federation of 14 different parliamentary networks from different fields that have come together to discuss global health in a safe space where we can all discuss these very challenging issues together. And of course, multilateral institutions, international financial institutions have a very important role in developing the right financing mechanisms that make sure that we incentivize and celebrate those countries that are actually keeping on track when it comes to reaching the Sustainable Development Goals. This whole international structure of multilateral organizations, not just specifically within the health organization and the global health space, but among all different aspects and angles, need to be aligned. We are living an unprecedented crisis in our lifetime when it comes to food, to energy, to climate, to finance. And so there is a need, and more than ever, for multilateral organizations to be able to fulfill their mission and to get everyone together. You know, looking at climate change, looking at the Paris Agreement, looking at the Sustainable Development Goals, it is very clear that we need governments at all levels. We need, of course, representatives in parliaments, congresses, and senates. We need multilateral organizations, and we need community-based organizations, all to be able to work together. And when it comes to hepatitis, we have a tremendous opportunity ahead of us, because unlike in other fields in which we still do not have the tools needed to eliminate these diseases, that is not the case for hepatitis. And so we should embrace the opportunity that is ahead of us and get the job done, the job that many generations before us has started. And that is also why we believe it's time to unite. Thank you.
Excellent. Thanks so much, Ricardo. Thank you. We're just on the hour, but since we started a bit later, I'm just going to take 5 minutes, if that's all right with the technicians. There are some great questions in the chat, but unfortunately, I don't think we'll be able to go through all of those. So maybe we'll just have one more round of kind of a general kind of final thoughts and wrap-up question for all of the panelists. And I think it's such a great point that we're in such a difficult time in so many ways, right? We just come through COVID-19. We're facing food shortages, cost of living increases. Through all of this, we're trying to achieve the SDGs and we're trying to eliminate hepatitis. So maybe it would be great for all the panelists just to give some final thoughts and just say, in the current environment, how do we think we can move forward, with the SDGs and, as part of that hepatitis elimination? So maybe we can start with Doug.
I'm inspired by some of the thoughts, and I share a lot of the interest in these ideas around. I think the urbanization point is very important. We've got to find the people who are vulnerable. this makes the most sense, and it hits so many political buttons at the moment. It hits so many economic buttons, and it hits all the right where the frames are actually coalescing. When we're talking about the finances, the human rights, and a lot of the political objectives. So really, and I think the global health strategy talks about the development of national plans and finding the vulnerable populations. And so this coalition around economic objectives, human rights objectives, and reaching the marginalized populations with services and technology which already exist, as we've described. I think these are the objectives which the SDG agenda has to support. And then other sectors will fall in line: finance, health, the urban, the SDG 16 and 17, about different partners, private and public, coming together. So I think target your assets towards the vulnerable, and I think you politically and economically are on the right lines there.
Excellent, thank you. And maybe we'll just start with Julia and go this way across the stage, if that's all right.
That's fine. Yeah, I fully agree. The challenges the world is facing at the moment is very big, and as WMA, that now health is competing with defense makes us very, very sad. But that's why we think the holistic approach, this healthcare system strengthening and universal health coverage, then we really reach everyone, including the most vulnerable one. And we don't need to choose, can this disease or this disease or this patient or that patient can be improved, then everyone would support from this.
Great, thank you.
I think the past 2.5 years or so have been particularly difficult given the COVID pandemic, which is, and you know, behind us seemingly in some parts of the world, definitely not in others, and obviously the economic challenges that are ensuing. I like to see silver linings, and I think if there is a silver lining to what's happened, it's that the world has really put a clear focus that we actually can't put health in the too hard basket, and that the cycle of panic and neglect, which has typified the way that the world's approached these issues over recent decades, needs to end. So we have this window where people are focusing on health. Some may say that it's closing because, at least in some parts of the global north, people are just getting on with their lives and forgetting about the pandemic. I hope that's not the case. Speaking about sort of health more broadly, I think we need to ensure that we don't put emerging infectious diseases, which is what we've seen with COVID, in a silo over here, and that's the focus, a little bit like Julia said, forgetting that without resilient and strong health systems, we don't have what we need to prepare for the next pandemic. So we have an opportunity, but we have to be really careful not to be myopic.
Excellent, thank you. Professor Ali.
Yeah. Actually, we know that this no strategy, that is SDG strategy, is independent. Alone cannot fulfill all the targets. It depends on the success of other strategies. So it's a combination of efforts among all the 17 strategies should gradually be implemented so that to get the net result, particularly for us, that is this 3.3 relating to the communicable diseases and viral hepatitis. I think each and every government should come forward actively and thinking that the elimination of viral hepatitis should be an investment process, like for investment for other projects and like this, so that the viral hepatitis status and health of the peoples can be uplifted, and the elimination 2030 will be fulfilled. Thank you, everybody.
Excellent, thanks so much. Jose, please.
Thanks very much. I think I focus my recommendations around first the need for metrics. I think, again, the ability for us to track and communicate progress across the HCV response metrics is critical to convince policymakers to allocate the funding. No progress translates into no money, but progress could translate into money. The second is obviously engaging with community, which we've done very effectively in HIV. within the HBV and HCV, but particularly HCV space, there's a tremendous amount more work to do. And that engagement is not just having them at the table, but having them actually help to plan, implement, and monitor HCV responses within countries and cities. And then finally, I would say there's an important need to link to the health and social equity agenda in a way that promotes HBV and HCV elimination within the context of a broader agenda that speaks to the dignity of all people, irrespective of their gender, race, etc. So those are three items that come to mind.
Excellent. Thank you so much. And Ricardo.
Well, I guess as we're coming to an end, we can say very clearly that access to health needs to be like true love. It needs to be unconditional. And the truth is, it is too conditional in many parts of the world, and therefore universal health coverage, which is clearly a target for everyone, is far from being achieved. And I underline what Jose said, when we need to measure very clearly what we are achieving, and so we also know where we need to go and to make sure we're on track. And that means that we need to measure not just at the national and multilateral level, but also at the local level. And I remember when in 2015 I was deputy mayor, creating a local dashboard for the city to know how we were doing in terms of SDGs. We all need to get involved, and we need to make sure that the community is involved, or else the most vulnerable parts of society, those that live at the margins many times of society, will be forgotten. And the principle, the vision, the dream of UHC will be lost in the details. And another point I would like to leave is that when it comes to pandemics, COVID-19 should be a never again moment. And now that we are discussing the possibility of a pandemic treaty, we see already as members of parliament, we are seeing backlash already based on something that isn't real yet. And as the negotiations go on for proper treaty or convention, it is important that everyone gets involved and motivated, and that everyone's point of view is included, so that we can make sure that in the future we are not caught in a trap where an outbreak becomes a pandemic. We are capable of preventing future pandemics so that we can keep populations safe. We have seen the trillion dollar impact that pandemics have. And lastly, viral hepatitis represent the low-hanging fruit of global health. We have what is needed to end viral hepatitis, to end Hep B, to end hepatitis C. Now let's unite and get that job done. Thank you very much.
Excellent. Thanks so much. Yeah, and in the spirit of unconditional love, I would like to thank all of our panelists. And it's been an amazingly, it's been a great session. It's been very insightful. I learned a lot, and I'm sure everyone else has too. Just a few housekeeping. After this session, we have 3 parallel sessions for you to choose from. One, bridging the gap in Hep B care and treatment. Second one, youth can't wait, which I'm very excited about as well. And finally, reaching communities that need it most. So 3 great topics. So thank you, everyone online, for participating. Thanks, everyone in the room, and enjoy the rest of the conference. Thank you. Thanks very much.